had a patient who wants multifocal IOLs but has quite dry eye. Do we do it? Do we not? Tune into this to find out whether we did. So this was quite an exciting case, Masara. This was a case about how we optimise the ocular surface to give a patient exactly what she wanted in the end. So this lovely lady walked in. She was an 81-year-old female who has been told she's got cataracts. Her general health is pretty good. She's got some mild hypertension. She's a varifocal wearer, no contact lenses. And the caveat is she wants to be completely spectacle independent. No glasses, not for distance, not for intermediate, not for near. If she's going to have this done, she doesn't want to have to wear glasses. So she came in and presented to us. If we look at her visions, unaided, she's about 6'9" for distance and about N14 for near. Her best corrected is 6'9" binocularly, and then you're looking at N5. So what we have to achieve is at least that level of vision, 6'9", N5, and make sure she doesn't have to wear glasses. So when she came in, we did a macular OCT. As you know, using different premium IOLs, we have to make sure that the eye is entirely healthy. So we did a macular OCT, and actually her macula looks pretty pristine. Would you agree with that?
Yeah,
Looking
looks
at the
very
scans,
good.
it was a very healthy macula.
Excellent.
And we did some topography, so the pentacam topography and the biometry. And this is where things got a little bit complex. So when we did the biometry, we looked at the amplitude of astigmatism in both her eyes and compared that to her tomography. And looking at them both, they didn't quite match. So in her right eye, for example, she's got half a diopter of cylinder on the biometry, and with the pentacam, she's got a little bit more. The axes are tallying up. And in the left eye, she's got about 0.8 diopters with the biometry, but the pentacam shows a little bit more. And looking at the scans themselves, you know, the scans aren't that great. So you're looking at the cornea, it doesn't look particularly regular, maybe some slight warpage there. And when we assess the ocular surface, it was pretty poor actually. She had some punctate epithelial erosions, her tear breakup time was only 4 seconds, and it wasn't in the best shape actually. So we toyed with the idea of her being spectacle independence and her wanting to be out of the glasses. What would you do in this case, Masara? Would you give her trifocals?
I think based on this assessment, no, I would not be looking at trifocals. She's obviously very motivated, and I think we have to give these patients a chance. So if she's motivated and she's got time, then we can treat the dry eye and then reassess. I think that's always the best approach.
And that's exactly what we did. So actually we did treat her for 6 weeks post initial presentation. So we asked her to do a warm compress. And actually these patients that are motivated to be spectacle independent are really good at carrying out their home regime. They really want to get these premium IOLs, so they get on board with what we recommend really easily. So she did a daily warm compress. We also gave her the preservative-free AEON Protect Plus, which is 0.3% cross-linked sodium hyaluronate, so it lasts a little bit longer on the eye, which means she's not having to instill these eye drops more frequently. She can get away with 4 times a day, and it heals the eye really well. We also ask her to use some FML once a day. There's often an inflammatory factor going on with ocular surface disease, so just to calm things down and let her ocular surface heal and her dry eye get a little bit better. And then we brought her back into clinic to repeat her biometry and repeat her pentacams. And when we redid the scans, actually what was interesting was the amplitude of astigmatism did increase. So both with the biometry and the pentacam, you can see that the astigmatism, that right eye, is now around 0.7. So initially it was about 0.5, and we wouldn't have really considered a toric IOL in that eye, but having assessed her ocular surface and treated it, you get a true idea of what that cornea is doing. And we did actually then discuss doing a toric IOL in that right eye. And again in that left eye, again the cylinder is increased a little bit compared to the initial visit, and it both matches up with the pentacam and the biometry, and it just looks like a more accurate reading. The cornea itself, looking at that, the front surface was much better. The tear breakup time had increased to 7 seconds, and we were a lot happier with the presentation of her and how her cornea was looking. So we did actually decide to do a trifocal, and she did have toric IOLs, trifocals in both her eyes. And if we look at her post-operative outcome, 2 weeks post-surgery, she actually had phenomenal vision. So she had binocular 6/6 vision unaided, and her near vision was N5, and that was 2 weeks post-surgery. So
That's excellent.
Absolutely fantastic.
She must have been very happy with that.
She was delighted, and then we then sent her back with the AEON repair. So we just changed her drops a little bit. The AEON repair is 0.15% sodium hyaluronate, but it also has a vitamin A and E, which just helps against the free radicals and just helps further enhance the quality of her tears, and she was absolutely delighted. So this was a great case, and I think it just highlights the fact that if we don't address the ocular surface, if we don't really have a good discussion with the patient, we could be limiting them, limiting their post-ops.
Can I ask you a question? Would you recommend seeing the patient at 6 weeks after treating the dry eye, or could you do a little bit quicker? Is there a time frame that you would recommend?
I think generally 6 weeks is a good port of call. You know, you're allowing the ocular surface to calm down, especially if you're giving them some anti-inflammatories to use. Allow the time for the ocular surface to heal, get the tears back up to a level where they should be, so when they come in, we know that the scan's going to be more accurate. If you rush things, you just may end up with inaccurate scans again, and then you send them away again. It's much better just to take your time and sit on this, especially when we're giving premium IOLs.
Thank you. That sounds like a great recommendation.